Okay, so we've talked about the heart, the lung. So let's move down to the belly. Um, let's start with, let's see. Um, let's start with pancreatitis. Okay, this is a very, you know, pancreatitis patients can be super sick. Um, what do you do when you have pancreatitis, right? Patient will have abdominal pain, lipase is up to the roof. They have, they may or may not have CAT scan findings. They may or may not have pancreatitis in the past. So what you need to do is find the etiology, right? Gallstone, alcohol, they're always the most common ones. Um, Sometimes biliary strictures, sometimes pancreatic mass, sometimes, I don't know what else. There are a lot of other zebras, but you need to make sure. Oh, and then check a lipid panel. Sometimes their triglyceride levels are up to the roof too. So you do need to address the secondary causes like stricture and stuff. You need to do RCP. You can start with the MRCP to look for the strictures or look for stones. If ultrasound is unrevealing, right? So the other thing is you keep them NPO, right? NPO, pain control. This is when you can actually give. You should probably be lenient about narcotics in this situation. It's very painful. Most importantly, fluid. So fluid. Um, we will always do 250 LR. So 250 LR is what it's the fluid. So then you carefully watch for complications. It does happen a lot. So I've seen a lot of times in the ICU, they go from pancreatitis with fluid to um, fluid overloaded and become hypoxic, and they may need to be intubated from respiratory failure because there's too much fluid. And then the other thing is pancreas, when it's inflamed, it can cause fluid transgression from below the diaphragm to up the diaphragm. So it's just like pancreatic like inflammation can do that. Um, but still, you just pray there's no complications, but it does happen a lot. So what do you do with pseudocysts? Usually, unless it's infected, do not do anything about it. Unless they're, especially in the fourth full month, they're not matured. Nobody want to poke it. I think pancreas is the last organ that surgeons or IR want to touch because you touch it, it gets angry. Um, so moving on to liver, so cirrhosis. Um, Again, find the etiology of cirrhosis. Do they have chronic hep C? Do they alcohol cirrhosis or autoimmune hepatitis? There's a lot of reasons for cirrhosis. So one thing you look for with cirrhosis is it compensated or decompensated? Usually they won't come to hospital unless they're decompensated, right? They're decompensated from what? So they are decompensated and they have a lot of ascites. Um, they are overly jaundiced. Um, Honestly, the other thing you need to look for is with pre-end stage cirrhosis, their AST, ALT are okay because their liver cells are just, or hepatocytes, try to be more medical. They're burned out, they're dead. So you don't actually see much of AST, ALT. Um, so sadly, we don't have hemodialysis for liver. Sadly, for those decompensated cirrhotics, it is symptomatic control, right? If they have too much fluid, drain it. You do a para. Um, and then you treat them with Lasix, right? Lasix, aldactone. It's usually aldactone 100 to Lasix 40. Um, kind of try to diurese them, right? The other thing, you treat them the underlying causes, right? If there's drinking, well, encourage them to stop drinking. Um, the other thing is lactulose, right? Lactulose to titrate for 2 to 3 stools per day to try to get rid of those toxins, like the ammonium toxins. Then you look for, when you have cirrhosis, those decompensated cirrhotic patients, you look for, do they have hepatoencephalopathy? Do they have this kind of asterisk? I can never say that word, but you know what I mean. Do they have hepatorenal? So you usually want to challenge them with a little bit of fluid if their kidney is worse. If it gets better, usually it's probably a little bit AKI and stuff. If it doesn't get better, it really could be hepatorenal. Then there's really not much you can do. So I do see with third spacing and all that, people get hypotensive with cirrhosis. So what you can do, I've seen people on Midodrine. It does work pretty nicely, but it does not make sense for people to be on Lasix and Midodrine, but it does happen. The other thing is you can determine like the MELD score or child class, and see if they qualify for liver transplant. That's really the only solution. See what else I'm trying to think. With cirrhosis, you need to make sure they have all the prophylaxis, like are they vaccinated and against Hep A and Hep B. Now with cirrhosis, do they actually have esophageal varices? And if so, that needs to be like a yearly EGVs. I know GI docs like to do ultrasound of the liver for like surveillance for HCC. So you do ultrasound, I think, every 6 months or every year to look for that. That's all I can think of for the liver. Oh yeah, the other thing is when you drain someone, like when you ask the IR to do a drain, or a paracentesis, you need to make sure if they remove a large amount of fluid, you need to replace them with albumin. There's a ratio that I cannot remember, but with certain, like say if they move 5 liters, you need to give them back albumin. You really, and then the other decompensated liver failure you can do is do tips, but you have to make sure this guy or this patient is lucid, because tips will make even a normal person's ammonia jump from like 10 to 200. So if their ammonium is 200 to begin with, and horribly hepatoencephalopathic, they're encephalopathic to begin with, that is not a procedure. And if they have history of HE, I don't think IR will actually do it either. So you need to make sure they're the right candidate for tips. I think that's all I can think of for now for the liver. So the other thing, commonly we see, probably pretty common, GI bleed. Is it upper? So then you will look at are they stable or not stable. So you will see unstable ones, in the ICU. So whatever they are, you need to do a couple things. You need to do 2 large bore IV. If they're super unstable, you should do a introducer in the neck. It's kind of like a large CVC for transfusion, and you should probably activate the massive transfusion protocol. But for people on the floor, they're hemorrhaging from a little ulcer, it's probably okay. Just do 2 large bore IV. If it is upper GI, you need to start IV Protonix BID. There are places they do drip, but right now I think BID IV is fine. You do need a type screen or type across for red blood cell. If they are on Coumadin, if they're on, if they're, like I said, cirrhotic P patients, you probably need to prep some plasma as well. If they're on Coumadin and bleeding out, this is when you actually have to reverse them with vitamin K, with FFPs, and I think you can use, it's a newer agent called PCC, if I remember right. It's super expensive. You may not be able to even order it, but on textbooks you will see that. So then if they are really unstable, that's probably you need to, give them blood, because they're losing blood. Don't just give them fluid. It doesn't work. Give them blood, give them fluid, but you need to give blood, okay? Also probably need your GI attending to be there to scope. I've seen a posterior, like a posterior duodenal ulcer. It's really close to the duodenal artery, and I think that patient might have eroded into that artery, and he just wouldn't stop bleeding. That's scary when they won't stop bleeding. It's really hard to stop. So when they actually start to bleed, EGD is sometimes a valid form to stop it. If you cannot find bleeding, but their hemoglobin is dropping, so you need to monitor hemoglobin at Q6, right? So if their hemoglobin is dropping, the other thing you can do is do nuclear medicine, like a scan. So they will tag the blood with a radioactive material, so when it bleeds, you will see a bunch of like black markers. You'll see the bleeding. You can also have IR. They shoot dyes and do angiogram. They look for bleeding. For the lower GI bleeds, a little bit easier. You can prep for colonoscopy. But then between EGD and colonoscopy, there's a decent amount of small bowel that's not evaluated, right? So a lot of places you can do capsules. So you do capsules, you look for AVMs, angioectasia, or that kind of stuff too. Then you can do double balloon, and there are fancy GI stuff that as a resident you will never do, but they have fancy stuff that you can do. So basically for you need to do 2 large bore IV or introducer, type and cross, and give blood as needed. Monitor H&H or CBC Q6 or Q8, whatever you feel the need to. IV protonics if it's upper. IV octreotide if this is actually cirrhotic. So, is there anything else that I'm missing? Oh, and then check for PTINR, definitely, if they're, and you need to know the history of patients on anticoagulations and stuff, then you need to reverse it. Okay, these are the basic GI stuff.